I make the analogy about the various iPhones and Androids and everything else we've got in between that have been upgraded from 2022 to 2025. So has artificial intelligence evolved just as rapidly.
Welcome to the Business of Healthcare podcast. From the Center for Healthcare Leadership and Management at the University of Texas at Dallas, Naveen Jindal School of Management. Here at UT Dallas, we bring together business heads and other thought leaders to help navigate the challenges of our rapidly changing, increasingly complex healthcare ecosystem. I'm your host, Professor Dan Karnuta, Director of the UT Dallas Professional Program in Healthcare Management. Be sure to subscribe on Apple Podcasts, Spotify, or your favorite podcasting app to ensure you don't miss any future episodes. You can also join us online at businessofhealthcarepodcast.com. In this episode, we're going to continue our examination of the very hot topic of artificial intelligence in healthcare. In recent episodes, we've delved into the use of AI in the back office business process side of healthcare, and we've also looked at the creation of a standard that will govern the use of AI in healthcare. But in this episode, we're going to take a look at AI's use in healthcare delivery from a provider's perspective. To guide us through that, we welcome Felixia Colón to the podcast. Felixia is a Senior Vice President at SCP Health and also a Fellow and past President of the American College of Healthcare Executives. Felixia, welcome to the Business of Healthcare podcast.
Thank you so much, Professor. I feel so honored to be joining you today.
Well, it's all our privilege. And let's start out by tell us a little bit about SCP Health and your role there.
So, as you stated, I am the Senior VP of eHealth. And when you think about healthcare delivery, I do want to explain SCP Health in terms of the care delivery that we do provide. Since we are a clinical integration company, I know a lot of people ask, what is that? And we are simply a company that can come in and manage, employ, hire, fire, train your EM, HM, ICU clinicians. And clinicians for us means anybody who's a physician or a nurse practitioner or physician assistant. But again, I think we bring a different perspectives because our healthcare delivery is not pocketed to one facility, it's not even pocketed to one region. We are in over 37 states. We have over 7,500 clinicians. We have over 585 programs, and we do close to over 10 million annual patient encounters. So when you think about our landscape, it is very broad. And in regards to AI, this will help explain why our company has taken such a big interest in it.
Well, let's go back just a few years, say to 2022, and what has changed and what is basically the same regarding technology and AI and the healthcare delivery now compared to just a couple of years ago?
Yes, and thank you for that. And I like to put into context, like how many evolutions of a smartphone have we received collectively between 2022 to 2025? And you almost have to think of artificial intelligence evolving that rapidly. When you look at artificial intelligence, especially in the healthcare industry, back in 2002, it was more focused on diagnostics and predictive analytics. Now here we are in 2025. And when you think about everyday applications, that's really what we've moved towards. So the personalized medical treatments, the virtual health assistants, varying workflows, including for us, how we optimize the workforce. And you even have artificial intelligence doing things like medical imaging on top of what a physician like a radiologist would already look at. And this is like a secondary review. So it has evolved tremendously. And again, I make the analogy about the various iPhones and Androids and everything else we've got in between that have been upgraded from 2022 to 2025. So has artificial intelligence evolved just as rapidly.
And what areas do you think will be most affected in the short term by AI in healthcare provider operations?
I really think that what is going to be the most effective is, of course, workforce optimization. We all know that there is a shortage, no matter whose industry that you look at, healthcare in particular. COVID really highlighted the need of the gaps in healthcare, but then it also burnt out a bunch of clinicians at the same time. And that's anywhere between case management, social work, the techs, the nurses, the physicians on top. So when you're trying to think about the best way to manage costs, especially if you're a hospital, you almost have to have predictive artificial intelligence that will show you the volumes, show you seasonality. So therefore you can ebb and flow right along with the patient volume that's coming in. Otherwise, what you're doing is that you're staffing to the maximum of what you assume would be patient care volume, but then you automatically hit the minimum, and then there you go, you're already missing your financials. So we think that in terms of labor, it's going to be that, but then also clinical decision support systems. So the EHRs that exist within these hospitals, no longer is it going to be a decision tree, meaning you move from A, then A sprouts out to option A, B, C, then you click C and it sprouts out to C, D, and E. We actually do think that with the EHR systems leveraging artificial intelligence, it's going to be a secondary review of that patient's case. So I know in contradiction that a lot of physicians feel like, artificial intelligence is taking away the art of medicine. For an operations person like me, we have the business of medicine, meaning we need to refine, maximize documentation so we can build to the highest level of acuity of what that patient actually has. And then somewhere in the middle is the patient. And if you look at a Venn diagram, the patient should always be in the middle. But when you think about artificial intelligence and how much of the clerical work is bogging down the physician's time frame, when it comes to art of medicine, they can't focus on that because they're too busy clicking through the different decision trees in the EHR. However, if you have artificial intelligence that's tied to the EHR and it presents, hey, doctor, based on all these components, we think the patient could also have this as a secondary chronic condition. That is helpful for a physician. And so I know that there's debate related to how sophisticated and how much artificial intelligence the EHRs are going to use, but it's almost a necessitated factor when you think about how complex patients are coming into the hospital now and doing an overall assessment to ensure that nothing is missed when it comes to treating that patient for all of the conditions that they have and not just identifying one little ailment and then they go to their primary care and have 15 other things and have to go back to the ER.
Yeah. And we can bring that down to a personal level. If I know when I go to my primary care physician every year for a physical examination, he does the physical and then he'll sit there in the examining room with me with a computer screen, going through his EHR's electronic health record system, doing what you just said, just doing a bunch of clicking and having to type in stuff. And we've gotten used to that as part of this is just how we do things today through computers. But it does take a lot of time. And there are a lot of drill downs and clicks that the physician has to do. And if he or she didn't have to be spending the time doing that, if artificial intelligence was helping out, then more productive for everybody involved.
You are absolutely correct. So I know there is one sector of artificial intelligence that is fastly growing, and that's the ambient listening. Would love it that a clinician going into the clinic or, you're in an urgent care or in the emergency room, they actually can wear a shareable on their lapel, like a little microphone, and it pick up all the conversation between the patient and the physician. And then imagine that all of this is kind of sorted into a, hey, doctor, this is what the patient stated as an issue. We interpret that the patient was trying to explain X, Y, and Z. And then from a physician standpoint, they don't have to go back to their desktop at the end of their shift and try to remember every little thing that they talked to in regards to the patient. And I think that a lot of us, especially who are in the healthcare industry, don't really understand what it means to be a non-healthcare person receiving healthcare for the first, second, or through their lifetime. The way that the average bear describes an ailment is not the same way that someone in healthcare would describe an ailment. So you almost leave that interpretation to a physician to say, my elbow hurts and it's radiating down my arm, to a patient really saying, I'm concerned that I have a heart condition. And every time that I eat something, this is the pain that I experience. So I'm hopeful that with the ambient listening and then the AI that is going to be embedded into these EHR tools, it's going to be able to help bridge the language barrier many times. And it doesn't have to do with somebody speaking two different languages. It just has to do with somebody interpreting what the patient is saying and then them translating it into a note later on.
Yeah, it's fascinating. And if for our listeners that aren't really familiar with the healthcare billing process, in order to bill whatever payer is paying for the service that the clinician is providing, there has to be documentation of what's been done. And then that documentation needs to be accurately turned into a billing coding process so that the right code gets put on the medical claim, and that claim gets sent to whoever's going to pay it. And they review it and they pay if it's all correct.
Correct.
And so what Felicia's talking about here is, this ambient listening. Again, it takes a lot of time for a physician to do all this documentation. And some physicians walk around with a small recording device where after they see a patient, they'll talk into it, and then they'll give that to someone at the end of the day, and that someone will transcribe everything that's been said into that microphone into a bill for all the patients. So it's a complicated process, and it has to be accurate. And if we can get AI to help with that and do a lot of that, and at the same time, like Felicia, like you just said, actually advise, or AI takes a shot at, here's what I think the patient was actually saying, that's helping everybody out at the end of the day. And have you seen any examples yet, call it this AI version 1.0 of this happening today? Or is it still just, here's what we think's coming?
I think we see it happening today, and there are several EHRs that are exploring this specific for their respective product. But I want to take it a step further from the 1.0 and do a 1.12, which is somehow leveraging the discussion between the doctor and the patient to enhance the patient experience. Meaning, hey, doc, you really didn't answer the question that the patient had answered or had asked you about, or that there is some other opportunity for the physician to understand from a humanity standpoint what that patient was actually trying to say. And I go back to the analogy about the pain radiating in their left arm. We all know that, again, for a lot of us who don't experience healthcare on a regular basis, who are in the industry, one of the things that can impact patient satisfaction in their experience is whether or not they feel the clinician heard them. And in that hearing them, that's where you can actually try to get to the root cause of the issue, but more so treatment as well. We all know that patients are more compliant with treatment if they felt that the physician heard them correctly. So when you're talking about the 1.0, 1.0 is picking up our conversation. The 1.1 is you are interpreting how me and the patient interacted so that I could be a better clinician at the end of the day in my interactions with patients subsequent of that visit.
Mm-hmm. On the clinical side of healthcare delivery, what kind of AI advancements are you seeing there, or are you planning for in the near future?
So I think it's one thing to have advancements, but I would like to pivot the conversation a little bit and talk about the security associated with it. So I know our company and probably many other companies, including hospital systems, want to ensure that the clinicians are using AI appropriately, right? We shouldn't chat GPT and everything else an ailment, right? This needs to be an actual interpretation of what the patient's experiencing. So I know our company came with guardrails associated with the use of artificial intelligence in their everyday clinical work. So I know that you were asking the question in one way, but I feel that we need to discuss and target what cybersecurity, how the physicians are leveraging it, along with NPs and PAs, how nursing is doing it, because it still needs to be addressed morally. And artificial intelligence can't be used as a shortcut and let me drop in every little thing that I needed to then answer, copy and paste that in an EHR. That's not going to work. So cybersecurity and the appropriate use of AI as a relative to the clinician is going to have to be the number one topic before we can even start addressing, how do you then use it? No, let's talk about the guardrails. Then we can talk about how you're going to use it appropriately for your everyday work.
Interesting, because we've got an episode where we talked about the standard setting process. There's a group of people who are actually doing that now, setting the standard for using AI in healthcare. And one of the topics we covered there was, do providers realize that their clinicians may be using AI today? And are they putting up these guardrails you talked about? Or do they not know that's even going on? So they're not putting up the guardrails, and therefore things could be happening that really shouldn't be as far as AI goes today. So it's interesting that at SCP, you guys are making sure you've got the guardrails up first, and you've already crossed this bridge or figured out that we could have a problem here if we don't get in front of it.
Correct.
So does that mean that now that executives are starting to figure out that, wait a minute, let's put the brakes on AI until we figure out how exactly we're going to use it? Does that mean it's going to be quite a while before we see the smart hospital concept come into play?
It is. I think there are certain elements related to the smart hospital. And before we hop on a smart hospital, I want to take a step back and think about it from an administrator's perspective when it comes to AI in the use of predicting the growth that's going to be happening, seasonality, variability in age difference. If you need to start having more of a geriatrician as opposed to a pediatrician, that is part of your clinician panel. And so what I mean by that is we are in a large metropolitan area, as you know. And when you think about what's going to be the next suburb that pops off to where you need to have a hospital built, you want to be the first one that is in the new frontier. However, you also need to make a correct financial guess as to where that growth is going to happen. So we all know that growth is happening north of the Metroplex, but then at what point do you say we need to drop a hospital over in that area? Because we know that the aging population over 65 is going to need a facility. And oh yeah, let's build a women's hospital because we also have seen that there's going to be the need for having pediatricians and OBGYNs in that area. From an administrator standpoint, I would so be using AI as a tool in order to predict what growth is going to be 5 years from now for a certain suburb, to decide whether or not to expand my existing hospital where I'm at because growth is going to happen here, or start to look at new areas to where you start building another hospital facility. So there's that one part. When it comes to the smart hospital of the future, one of the things that you have to think about, and one of the things that I've seen, is that we all recognize that there's a nursing shortage. We all recognize that there is a tech shortage. We all recognize how expensive to have a sitter be at a patient's bedside just to make sure that they don't fall out of bed. A lot of the technology that has come out on the forefront is predicting, depending on how a patient sits up in bed, as to whether they're about to get out of bed and to whether they're going to be a fall factor. So you can almost set off an alarm just by a patient moving one way to ensure that a nurse is at their side because that patient was really going to go to the bathroom and felt like they wanted to do it themselves instead of hitting the nursing button for somebody to come and help them. That is one great area. Another thing of the smart hospitals of the future is we've all seen, if you've gone to visit a family member or been hospitalized yourself, the lovely whiteboard that has the dry eraser marker. And it's like a physician, when you go visit someone, it's like, is this your doctor? No, that was a doctor I saw 3 weeks ago. What? So it'll be great to have almost like the whiteboards be electronic. So that way your family members can see what your labs and what your vitals were if you decide to allow for that permission to be on the whiteboard. But then it can update the physician. It can show you who the nurse is. I've even seen one hospital system that is going to be, they're pushing to the smart hospital of the future. And instead of depending upon a person to appropriately introduce themselves to the patient, because the patient sees 15 people in scrubs. They don't know if it's their doctor, physical therapy, pharmacy, or the nurse. There was one system that we went to go see, and as a person walked through the room, it read the badge and it showed on the whiteboard, that electronic whiteboard, who that clinician actually was and what they were doing. So it showed the difference between the radiology tech coming in versus the physical therapist coming in versus the nurse versus, ta-da, this is the physician. And I thought that that was just great, but how it recognized it was by biometrics. So as the person came in, it wasn't just off their badge, it was literally off the biometrics and the badge that it read that fast when the clinician crossed over the door. So when you think about even from ensuring that we know as the caregiver who our loved ones are seeing, but then our loved ones can be educated to also know who's coming in and out of their room. That's a really great thing, especially for someone like myself who has aging parents. And my mom was recently hospitalized, and it's like, well, did the doctor come and see you? And she's like, I think so, because she had 15 people come in her room with scrubs on. And I would have loved it had this technology been in place, because she would have clearly known who the different people were coming in and out of her room.
Yeah, so that smart hospital of the future stuff is all the interesting piece of AI and how it's going to be applied, and is the marvelous things we're going to see with it.
This episode is brought to you by the Center for Healthcare Leadership and Management, the definitive resource for healthcare management education in North Texas. The center is based in the Naveen Jindal School of Management at the University of Texas at Dallas. It plays a unique role in training the next generation of healthcare leaders to meet local, regional, and national demands. The Jindal School uses its strengths in accounting, administration, finance, marketing, and information systems to educate highly qualified personnel for healthcare administration and executive leadership positions. The center is home to 7 healthcare leadership and management programs, including undergraduate and graduate programs, as well as executive programs for physicians and working professionals. For more information, visit us online at jindal.utdallas.edu/healthcare.
If we back off to the more mundane piece, you as an operator, you talked about workforce optimization before, and that's something that again, a lot of people don't realize about the healthcare sector, especially like a hospital. It's making sure that there's the right level of staff at the hospital at the right time, the right number of nurses on the right floors at the right time. And so that's workforce optimization becomes a big part, I'm sure, of what you do. And how is AI affecting that, or do you think AI will be affecting that in the future?
So I'm going to toot the horn of the organization that I work for, in the sense that they have leveraged artificial intelligence to serve as a predictive model for what we think volume is going to be patient-wise. And we have it predicted both for the emergency medicine side and the hospital medicine side. So, you have patients who show up every hour on the hour in the emergency room, and then there's a percentage of patients that we admit on the hospital medicine side. In order to appropriately address clinician burnout, you almost have to predict what kind of day they are going to have when they step in, right? Back in the day, before all of this AI and all of the savvy things that we've got now came into play, if you came in and 15 people had checked in the emergency room, well, your day went from good to womp, real quickly, and you just had to grind through that day. As it relates to what we're doing now, we have the capability of not only predicting the different volumes, so all the peaks and the valleys. From the business standpoint, you want to always staff to the valley, but then have plans in place for the peaks. And so for the peaks, we are doing things like leveraging virtual hybrid care to help address some of that. You can almost call in a shift ahead of time, because we can predict that Mondays and Tuesdays are busier than Wednesday, Thursday, and Friday. And if it happens on a random Friday, then we have virtual hybrid care that can kick into place. So our goal, when you really think about it from an operation standpoint, is to really refine coverage models to the volume that's coming in. But I think of it in a different way, because I am responsible for launching all the virtual hybrid care service line for our company. And it's saving someone to have a good day, in order so that way when they leave the hospital, they can be more engaging with their family. There's so many downstream effects of that. And so as it relates to our organization and how we are leveraging AI, business-wise, it's like, yep, I want to refine the pennies and the cents to the hours of coverage. But in understanding what this means to someone is, I'm getting out at 7 p.m. What this also means to someone is, oh, shucks, I can eat lunch today. It doesn't mean that now we have one physician who's going to be seeing 35 patients because AI is in here and it does all these things to offload some of the clerical burden. That is not what we are intending to do. And I honestly feel that's not what the industry is trying to do. The industry is trying to salvage the clinicians that are here today, because we provide a better work environment. You can't stop the bus from coming in and bringing in 15 people, but what you can do is be prepared for that. So you can staff accordingly on the nursing side, and you can staff accordingly on the clinician side. So, Professor, I know that was a long-winded answer, but I hope it provided a kind of like a deeper level of why this matters so much to us to have that workforce optimization drilled down to the wire.
Yeah, it did. I think hopefully for our listeners who don't really think about the deep business side of healthcare, which part of it is managing the cost of the healthcare organization you're working for. And a big part of that cost in healthcare is the people side, and it's optimized. You don't want to have too many people on the shift if the patient volume doesn't need that many. And you certainly don't want the opposite either. And that's a big part of what we do as business leaders of a provider organization. So shift a little bit now to some other potential risks of AI. And one thing I've heard about and read about is the potential risk of, I guess, access to healthcare or healthcare equity on that front. Is there a danger that the equity gap could grow with the maturation of AI that could require technical knowledge or electronic device mastery that some people just don't have the ability or the means to have those? I'm thinking about wearables and those type of things. Could this widen the gap between the haves and the have-nots?
And it will widen the gap between the have and the have-nots. And even before you start talking about AI being given to the patient, let's talk about the digital infrastructure of the United States. I think the start of COVID helped us realize with our children and our students how many people really didn't have the internet, or at least appropriate internet to even support the video where they're trying to do training or learning with their teacher. So imagine trying to set this up for patients. There are some areas in rural America today, forget trying to have 1 bar, you got 0 bars. And the 5G is no G in some of these remote areas. And then you have to think about more metropolitan areas that there's so many people on the network to where your bandwidth slows down. So the digital infrastructure in and of itself will widen that gap, especially with, people trying to figure out if they pay for medicine, if they pay for internet, or if they pay for food. That should not be a decision that any American has, but sadly, that's reality. When you think in terms of healthcare equity, there is a way for this kind of technology to even the playing field. However, there have been a lot of articles and discussions lately that if the programmer and the AI doesn't come with the intent of doing a larger, we're going to call it cast the net, to ensure that they've got this bigger population that they look at, then it can sift through whatever kind of AI to come up with appropriate programs for these patients. You have to then understand that it has to have a bigger nest to pull all these patients in. What we're seeing is that they're narrowing or assuming, the AI is assuming that all the patients are already at an equal playing field with their healthcare, and that is not the case. So there have been situations and lawsuits that are out there now where whole subsets of populations that would be mainly impacted by that chronic disease aren't even included. So I'm going to give you an example, although this was not one of the cases. Imagine sickle cell crisis that impacts African Americans mainly, but there are a lot of biracial and multiracial kids now. So people can still have the trait and not have the actual sickle cell themselves. But imagine if you were looking for the system to just say, pull out these patients so then we can predict them for sickle cell program in advance because they have a trait, and then you're picking up a population that's not even succumbed to that. That's a problem. That means AI is not appropriately assessing on the front end who they're even trying to capture in terms of the patient population. So I use that as a more simplified way to explain how AI can come in with a bias. And trust me, I'm sure everybody's like, it's artificial intelligence. How can it come with a bias? Because if the programmers who do the artificial intelligence also have a bias, then what the program is going to be, although I'm sure people are not doing it intentionally, it will eliminate or not include certain subsets of populations. So one of the ways to help address this. And there are several healthcare organizations and even a telemedicine association that's looking at this, is to create almost like an AI telehealth governance. And the whole point of the government is to ensure that it's addressing biases, it's incorporating fairness, and not either whether that is to predict programs for your patients or to provide personal healthcare treatments, or to say you are now a candidate for a hospital at home. There has to be somebody that goes in and reviews the granular details associated with that to ensure that it is being given to patients equitably and not set up on some programming language that's excluding a whole subcast of patients.
Yeah, when you mentioned bias, bias isn't necessarily an evil thing. Yeah, a programmer might not even know the information they're feeding has a bias to it, just because they're unaware. It's a difficult thing to tackle on that front. And that if bias was easy to spot, and you can see it coming, then it'd be easy to tackle. But it's really not. So it's one of those things that I know there's a lot of people out there paying attention to and trying to get that right.
Correct.
So let's sum it up. So what should today's healthcare provider operations leaders be thinking about to prepare their organizations for what's coming on the AI front tomorrow? So what are you doing, not to give away your trade secrets, on your front to prepare for what's coming?
I think any healthcare operations leader needs to start working with their clinical team, the IT team, and yes, cybersecurity is not the same thing as your IT team, to start to create a roadmap in terms of where do you want to be in the next 5 years, 10 years, 15 years associated with not only AI, but then we talked about the comprehensive EHRs that are coming out. Do you start to incorporate to where you can have wearables for your patients, so almost like an automatic EKG machine that measures the heart rate, and you can discharge that patient sooner because now they've got a wearable for home. You also need to start thinking about how do you have the patient access their own healthcare. If you've got a complicated app that really is meant for a Gen Zer and not the baby boomer, you already have a problem if you expect for the patient to access this once they get home. So the operator really needs to come up with the roadmap, but it needs to be all inclusive. Include your clinicians, including nursing, case management, social work. Include IT because that's one build out, but then you also have to include cybersecurity because what you don't want is that there's exposure to HIPAA information or you put the patient in some kind of jeopardy of having their information stolen or hacked as a result of not appropriately setting up the cybersecurity on the front end. Not only that, but we all recognize that there has to be modern medicine of the future, and you have to leverage things such as digital health and things such as AI. And it's not going to be, are you going to do it? It's going to be how you're going to do it because it's here. It's here. There may be people who don't even know that they are falling into being touched by AI in some way. But, if you're over here talking about in your house, man, I don't feel too well. I need to maybe go to the pharmacy and get me some cough medicine. And then all of a sudden on your phone, you see a cough medicine commercial come up. Ta-da! That is what you're essentially going to call AI. But nonetheless, as it relates to hospitals and being in healthcare, imagine the future of this baby boomer population. I was looking at I think an article on the advisory board, and it said the baby boomer cohort, we have close to 10,000. I want to read this. 10,000 people turning 65 plus daily from now until the year 2030. How are you as an operations person going to be able to take care of that population? When you think about who's elderly, we used to say, oh, an elderly person is somebody in their 70s. I'm going to tell you right now, my mom will beat me up if I dare even call her elderly at her age. So now elderly is now shifting into this whole different category of like an 85 plus. So when you think about the acuity level of not only taking care of a baby boomer, but now it's generations of baby boomer because you got the 85 plus, you got the 70 plus, and then you got the newly emerging 65 plus. There has to be a way to take care of them appropriately without taxing and burdening the fact that they've got to go to the hospital system every single time. I feel personally that we're going to move away from the patient having to come to us, being the healthcare facility, and we're going to have to find ways to go to the patient. Again, I hate to use my parents as an example, but I don't want my parent driving back to the hospital for a post-discharge clinic, because then the primary care can't see them for 3 weeks, but then they need to go ahead and be seen, 2 days post-discharge. And my parents driving back to the hospital for that? No, no, no. What I would prefer as their daughter who's 1,500 miles away is that I can be involved with their healthcare. They can stay in the comfort of their home post-discharge and see the clinician on site. I also think about persons who have aging parents in that 85 plus range who do not, well, I'll put it like this. The parents do not want to be in a nursing home. They do not want a sitter to come there. Can you leverage some of the tools to serve almost as an electronic sitter, but with the patient, aka your parental unit at home, and so that they can have a more independent life, but it can almost predict if they're going to have a fall risk because of the time of night that they're trying to go to the restroom, or the way that their house is set up, or your parent seems to wobble when they hit, step number 5. So it's a multi-pronged response, Professor, in terms of what you asked for. But as an operator, you have to be thinking about the baby boomer cohort shifting into a different age bracket, but generations of that, 65 plus, 75 plus, 85 plus. You also have to think about how the Gen Zer is going to allow and have more comfort with technology in their life, right? So you got the baby boomer who's like semi-resistant. Then you got the Generation Z who's like, let the whole thing just run my life and I will be okay. So you have to deal with both of those spectrums as a healthcare operations person. But again, you need to be thinking about how do you optimize staff, right? You talked about it. Billing is part of our essential makeup in terms of dollars and cents and reimbursement. And how do we have the business side of healthcare run? But as reimbursement declines, as there's more competition for nurses to not be at the bedside, but nurses have got options. They can be at the home side. They can do virtual nursing. You're in competition with that now. And then, of course, you have the physicians, the nurse practitioners, and the physician's assistants. And you have to think about how many are actually going to medical school or doing a program now to what will be servicing that baby boomer cohort in the future. So again, long-winded answer, but it's almost like you have to think of both sides of the pendulum. And then you have to think of it personally as yourself, as what would you want your parent to experience versus what you want your child to experience. And if those two things aren't aligned, then as a healthcare operator, you need to start being a part of the conversation that is happening.
Yeah, it's complicated.
Yes.
Well, Felixia, thank you so much for being with us and sharing your insights on this. It's always fascinating to hear what you have to say, given that you confront this stuff every day in your day job. And we are so happy that you were here to join us today.
Thank you so much. It's such an honor to share my thoughts with you.
Well, we'll flip back and have you on a little bit later and find out just how accurate we were here.
Right.
All right. Thank you.
Thank you.
Thanks for listening to the Business of Healthcare podcast. To learn more about the Center for Healthcare Leadership and Management and the healthcare management business degrees and certificates available to seasoned clinicians, master's students, and undergrads through the University of Texas at Dallas, go to jindal.utdallas.edu/healthcare.